Hi, my name is Yuriy Bronshteyn. I'm an intensivist and anesthesiologist at Duke, and I will be presenting the March 2025 POCUS Case of the Month for OpenAnesthesia.org, Introduction to Lung Ultrasound. This lecture will serve as the first in a series on lung ultrasound, with the subsequent presentations covering illustrative cases. In this introductory lecture, we will cover four aspects of lung ultrasound: transducer selection, probe placement, key normal and abnormal findings, and multi-view image interpretation. Let's begin with transducer selection. Question 1. Of the transducers shown, which is likely to provide the highest spatial resolution at depths where pneumothorax is visible on ultrasound? The best answer is C, linear high-frequency transducer. This probe's high frequency permits high spatial resolution of the superficial space where pneumothorax manifests on ultrasound. More on pneumothorax later in this presentation. Question 2. Of the transducers shown, which can be used to identify deep lung pathology such as consolidations and pleural effusions? Multiple answers may be correct. Select all that apply. The best answers are A, B, and D. All of these are low-frequency transducers, which means that they permit visualization of structures deeper than about 6 centimeters in the body. Notably, probe D has many names in medicine. A common colloquial name for this transducer is phased array probe. However, this term is misleading because all modern ultrasound transducers are phased array, including even linear high-frequency transducers. So the term phased array should be thought of as a colloquial name only, and the technically correct name for this probe is sector array or sector arc transducer. In summary, lung ultrasound can be performed with a number of different transducers. If one is only interested in screening for superficial pathology, such as presence versus absence of lung sliding, then the best spatial resolution will be provided by a linear high-frequency probe, choice C. Alternatively, if one needs to evaluate for both superficial and deep pathology, then one will need a low-frequency transducer, such as A, B, or D. Among the low-frequency transducers, the microconvex and sector array are preferred for lung ultrasound because their small footprint fits well between ribs and minimizes rib-associated acoustic shadowing. Finally, when doing lung ultrasound with low-frequency transducers, it is usually helpful to do a couple things. First, switch from a cardiac to an abdominal or lung preset. This will accomplish two things. A, it will move the probe indicator to screen left, which aligns your images with standard radiology convention, and B, switching from cardiac to either abdominal or lung preset will decrease the screen's refresh rate and increase the screen's line density. This has the effect of increasing spatial resolution while getting rid of excess temporal resolution. The temporal resolution needed for cardiac imaging is not helpful for lung ultrasound because, as a general rule, the lung moves slower than the heart. So cardiac mode is not optimized for lung evaluation on most machines. A second tip is to turn off harmonic imaging. Harmonic imaging suppresses artifacts, whereas lung ultrasound centers on detection of artifacts, such as A lines and B lines. These two types of artifacts will be explained later in this presentation. Now that we have covered transducer selection, let's move on to where on the body to place the ultrasound probe in order to perform lung ultrasound. There are a number of different lung ultrasound image acquisition protocols, ranging from 2 to 14 views per hemithorax. Although a larger number of scanning sites increases the sensitivity of the exam for pathology, this comes at a trade-off of increasing the duration and complexity of the exam. To balance these trade-offs for purposes of introducing lung ultrasound, we will describe a focused exam that screens each hemithorax in 3 locations. The first view on each hemithorax is an anterior view of the upper lobes. This view is obtained by placing an ultrasound transducer at the mid-clavicular line, approximately between the second and fourth intercostal spaces, with the probe positioned in the body's parasagittal plane and the probe indicator pointing toward the patient's head. The second view on each hemithorax is an anterolateral view. This view is obtained by placing an ultrasound transducer at the anterior axillary line, approximately between the fourth to sixth intercostal spaces, with the probe indicator pointing towards the patient's head. On the right chest, this probe positioning will typically overlie the right middle lobe. And on the left chest, this probe positioning will typically overlie one of two places, either an anterior portion of the left lower lobe or the lingular portion of the left upper lobe. The lingula is the left-sided analog of the right middle lobe. The third view on each hemithorax is a posterior lateral view of the lower lobes. This view is obtained by placing an ultrasound transducer at the mid to posterior axillary line, approximately between the fifth and eighth intercostal spaces, with the probe position in the body's coronal plane and the probe indicator pointing toward the patient's head. Now that we've covered the basics of ultrasound probe placement, let's now review key normal and abnormal findings. Here's an example of an anterior and/or anterolateral view showing normal findings. Let's now take a look at what makes these findings normal. With the probe placed as shown in the top left of the screen, the anterior lung view should contain the following structures: a cranial rib casting its acoustic shadow, a caudal rib casting its acoustic shadow, the pleural line with motion across it that is synchronous with the patient's respiratory rate. We'll explain this motion momentarily. And a horizontal line called an A-line. The A-line is a mirror image artifact of the pleural line that is seen at a multiple of the distance between the pleural line and transducer. A-lines are, by themselves, a non-specific finding and occur in a wide range of normal and abnormal conditions. A mnemonic for remembering the term A-line is that the letter A has a horizontal line through it, and A-lines are horizontal lines on lung ultrasound. Let's now come back to the pleural line. The pleural line is a sonographic term for the bright horizontal line normally formed by both the visceral and the parietal pleura. When the visceral and parietal pleura are directly touching each other with no intervening air between them, this will appear on ultrasound as a pleural line with a phenomenon called lung sliding. Lung sliding refers to a large amplitude horizontal movement across the pleural line that is synchronous with the patient's respiratory rate. As shown in the cartoon illustration on the right, the sonographic finding of lung sliding is caused by movement of the dynamic visceral pleura against the static parietal pleura. In contrast, when the visceral and parietal pleura are separated by air, i.e. a pneumothorax, the air reflects all of the ultrasound energy back to the transducer, preventing the transducer from seeing anything deep to the air. This prevents the ultrasound machine from visualizing the dynamic movement of the visceral pleura and instead generates an ultrasound image of a motionless pleural line, representing the always static parietal pleura. However, a static pleural line can be caused by conditions other than pneumothorax. For example, the pleural line will appear motionless on ultrasound when the visceral and parietal pleura are stuck together, such as after organic or medically induced pleurodesis, or in situations where the examined lung is not being ventilated, such as emphysematous blebs or mainstem intubation. Another important lung ultrasound finding are B-lines. B-lines are a vertical ring-down artifact arising from the pleural line and propagating all the way down to the bottom of the screen. B-lines have the following additional features. They get wider on the screen from superficial to deep, and they efface or obliterate A-lines where the two intersect. Although 1 to 2 B-lines per rib interspace is considered a normal finding, it is, in contrast, abnormal to have a rib interspace with either 3 or more B-lines or large confluent B-lines that occupy the majority of the rib interspace. Such abnormal or pathologic B-lines indicate increased lung density, which can be due to fluid, fibrosis, or partial loss of lung aeration as occurs in early atelectasis or early pneumonia. A mnemonic for remembering the term B-line is that the letter B has a vertical line in it, and B-lines are vertical lines on lung ultrasound. Let's now move on to the posterior lateral lung view, which aims to examine the lower lobes for consolidation and the posterior pleural spaces for effusion. Here's an example of what this view normally looks like. Let's now break down the key features of this view. The superficial part of the image will show lateral structures in the body, whereas the deeper part of the image will show structures closer to the midline of the body. With the probe set to a non-cardiac preset such as abdominal or lung mode, the screen indicator will be on screen left. Since the ultrasound probe's indicator should be pointing cranially to obtain this view, that means the left side of the screen will show cranial structures and the right side of the screen will show caudal structures. This view should be centered on the diaphragm with the pleural space visible cranially and the liver or spleen visible caudally. Notably, in the normal posterior lateral lung view, the lateral edges of the vertebra, emphasized here in blue, should be visible as a string of scallop-like structures caudal to the diaphragm, but not visible cranial to the diaphragm. This is because the liver/spleen are solid organs that are good conductors of ultrasound energy, whereas air-filled lung is not a good conductor of ultrasound energy. In contrast, in the coronal view shown here, visualization of the spine, cranial to the diaphragm, rules in the presence of pathology and is termed spine sign. Spine sign indicates that the normally air-filled lung has been altered to permit good conduction of ultrasound energy. This is typically due to the presence of pleural effusion, lung consolidation, or both in this view. Now that we've gone over key normal and abnormal findings in single views, let's now integrate all of that to explain multi-view lung ultrasound image interpretation. Lung ultrasound can be performed for a variety of indications. For anesthesiologists, the main indication is pulmonary dysfunction, which can manifest as hypoxemia, hypercapnia, and/or respiratory distress. When a patient with pulmonary dysfunction undergoes lung ultrasound, the goal is to identify which of the 5 sonographic patterns the patient has, as each of these patterns has its own distinct differential diagnosis. Although notably, some patients may demonstrate more than one of these lung ultrasound patterns, indicating the presence of more than one kind of lung pathology. The first lung ultrasound pattern is sonographically normal lung. Anteriorly, this is characterized by all lung fields showing lung sliding and A-lines. Posterior-laterally, this is characterized by the absence of spine sign. The finding of sonographically normal lung narrows the differential diagnosis primarily to the following conditions: COPD asthma, pulmonary embolism, deep lung consolidations not visible with ultrasound, and/or intracardiac or intrapulmonary shunting. The second lung ultrasound pattern is focal absence of lung sliding. Focal absence of lung sliding narrows the differential diagnosis primarily to the following conditions: pneumothorax, mainstem intubation, emphysematous blebs, and/or lung adhesions. The third lung ultrasound pattern is unilateral B-lines. Unilateral B-lines narrow the differential diagnosis primarily to the following conditions: early atelectasis, early pneumonia, early malignancy, lung contusion, and/or evolving pulmonary embolism. The fourth lung ultrasound pattern is bilateral B-lines. Bilateral B-lines narrow the differential diagnosis primarily to the following conditions: hydrostatic pulmonary edemas, including congestive heart failure, negative pressure pulmonary edema, and/or transfusion-associated circulatory overload. Non-hydrostatic pulmonary edemas like acute respiratory distress syndrome, transfusion-associated lung injury, and/or preeclampsia. Multifocal pneumonias, including COVID pneumonia, and interstitial lung diseases / pulmonary fibrosis. The final lung ultrasound pattern is consolidation and/or pleural effusion. The finding of consolidation and/or pleural effusion narrows the differential diagnosis primarily to the following conditions: pneumonia, atelectasis, malignancy, pulmonary embolism, hemothorax, empyema, and any cause of transudative pleural effusion like cirrhosis, congestive heart failure, etc. This concludes our lung POCUS introductory lecture. For continuation of this series, including case examples of all 5 lung ultrasound patterns, stay tuned for more OpenAnesthesia.org lung POCUS cases of the month starting in April 2025.